Okay, can you see us, hear us?
Yes.
Very, very good. So I think a lot of our players have been same, except one of the fellow, our intervention fellow is Tausif Dar, and Anton Kamaj, and of course Huda is my assistant. And this rest of the staff is about the same, some changes for nurses and so. But just to go through this case, and why I wanted to come right away on this patient is because of uh, this. I'll show you what exactly happened. We go to live case number 10. You see 76-year-old patient who presented to outside hospital with chest pain, tightness, left arm, and has a significant left main disease. Because despite the normal stress test, then patient was sent to surgery and declined. So I just, while waiting, I counted. I actually have 6 surgeons. I'm not excluding Mount Sinai. 6 surgeons from New York, about 8 surgeons from New Jersey, and 2 from Connecticut who send me the cases because they don't want to do it. This is one of the case which came large, high BMI. Did we put a BMI here? You see the angiogram point of view, it's very tough to see, and a very significant left main disease. Right corner is non-significant, and there's a decreased flow in the LAD. This case appropriate with the syntax score. If we can go to the angiogram, please. Good. So this is case you see here. LV just kind of okay.
Very good. Very good, LV.
Yeah, and right corner about 30-50%, maybe a little bit of PDA 50-60, but that's not where the money is. Money is here in the left main. And as you saw that it's a radial case because today my goal is to make all the technique happy. So radial was complaining that no radial case is done. And this is the radial case. Of the 10, we have a 1 radial. So at least 10% by the end. And see this very significant left main, very
better than 0.
Yeah, like this here. This is the case. See, the LAD has a TIMI2 flow. And why I wanted to come back, patient came in with a blood pressure of 80 and a very calcific 95% distal left main, ostial LAD, and then of course the circumflex, maybe a little bit ostial disease. And you see the TIMI2 flow in the LAD. And so TIMI, not 2 with 3 minus. So with that note, while we are waiting, and clearly, I would say I won't even experiment this case doing the imaging because what are we going to see? We clearly went in 1.5 bar. As you see, many of the pictures we had to take on cine because you cannot see it because of the overall weight, but calcific vessel never had any intervention. 1.5 bar, this is where we were. And then we use a 2.0 bar. I knew that this case even was very difficult, 1.520, but we could have, this is the case, such a complex bifurcation. If not for the weight, as we talked about protected PCI, this is the ideal case you put a balloon pump or impella. But we avoided that because of the weight. This is the 2.0 bar.
Now, what RPM did you go? What RPM did you have to go?
150. It went through the 150. We just increased it, and we did the balloon dilatation. As you can see here, that too, everything has to be done on the cine. This is the 3.5 balloon? Yeah, 3.5, 12 millimeter, 12. We went to 16 atmosphere, post-dilated with a high, and then we did the IVUS. So I think because everybody would like to see the IVUS, and we have done the IVUS and also ostial circ, I use a 4-row score flex. We have angiosculpt score flex, a scoring balloon, or the Wolverine, which is the typical 3 or 4 blades. This is a 1 wire and 1 blade, kind of your own wire, so 2 wires, and you can go to very high pressure because of non-compliant. So this we went to 20 atmosphere, you hear, and now we have done the IVUS of the left main to LAD. If we can show the IVUS now, please.
Sure.
Show into the main screen, IVUS.
So now start
yeah,
from the
terrific.
LAD.
We can see everything. Go ahead.
Yeah.
Yeah, still eccentric calcified lesion flux LAD. Now come to the ostial LAD. You show the 360 calcified lesion still there. And this is distal left main, still like a 360 calcified lesion. And the MLD is 2.0 after loader in the balloon.
All right, so that's where we are now. We want to take a picture now. The question is, and I know there is a good talk on the atherectomy, on the IVL. Here we have done the atherectomy, we have done the scoring balloon. I think this is a case we want to hear from panel, but I'm ready to do the IVL. This case will need something more, and there's ostial left main disease, there's get ventricularization as soon as we engage, as you can see there. Hemodynamic will show it. Yeah.
Yeah, I
Okay.
mean, looks
So
like
we are
need to
ready with
go
the 4
for
IVL in the
over
LED.
here.
Yeah. Yes.
You have
So much calcium.
I don't know any other ideas from the panel. Judge, you also have a microphone there. If you want to make a comment, you just give us a talk on the IVL. I think, right now the lumen is 2.0, just exactly same as the rotablator. So everything else was rock hard outside where the rotablator burned. And we really need to go very, very big diameter here.
So one thing that also we don't know is how much incremental benefit does the IVL give you over regular NC balloon or cutting balloon or anything like that? I mean, we're actually doing a study shortcut trial in this setting post-rota. There's a stratification, IVL versus cutter. So we'll see. But I think we certainly...
I thought he did the IVUS after the high pressure balloon.
Yep.
Into the circle. I don't know if he did the
No, LED.
No, this is the IVUS to the LED.
Yeah. Got it.
LED.
So
the circle was a very short lesion, very austere little lesion. Go to 6. Sorry, 4 right now. And we are going to go to 6 because you can go up to 6 and then in the end up to 8 and you can see negative. So blood pressure, guy, tell them to show the hemodynamics.
But are you across
so
from
blood pressure goes down. Remember we talked about...
Are you across the bifurcation? We can't see here. You have to see it because indeed we can't see anything here.
Patient is very
I can't see. He's doing the ostium.
Join the gang, my friend. We can't even see without Cine. Okay, we are going to do it again. Now, Steve, go up.
The other thing across now. I think you're across now. Yeah.
The other thing you don't know from the IVUS is how thick the calcium is that's left. It's one of the reasons that I really like OCT for the evaluation of calcified vessels as opposed to IVUS. And you can't do that for the ostial left main, but for the distal left main, OCT works just fine.
That would be a good
if it was very thin calcium, then a balloon was going to break that.
Go up again.
Right? If it's very thick calcium, that gives you a whole different, then you need something like IVL.
It doesn't seem like a thin calcium here, I must say.
You absolutely can't tell. You can't tell. You really can't tell.
No, I can tell you. No, Greg, you can tell by the way your device works. You are not able to dilate after the 2.0 bar. It's a very thick calcium. And we have that IVUS. We have shown that.
No, that's be clear.
You didn't try a 3.5 or 4.0 balloon, did you?
So okay, let me just clarify because Dr. Sharma said everything very quickly. He tries to the case also. He tried a 3.5 high pressure balloon at high atmosphere, and after that he did the IVUS that had a minimal lumen diameter of 2.0.
So that 3.5 at high pressure opened or did not open? Oh, well, okay. Well, then you know. That's what we call.
So that's exactly what I said. Not every case. So see this now. You always have a little dent, even going with a 20 atmosphere. This was okay. Ostial circ nicely opened up with a score flex. But look at the balloons here.
Yeah.
We'll come to 1 second.
I don't know if we had a scene.
Yeah, that's what I didn't see is the score flex for the LED left main. Yeah.
You see that on the top. The top crater will never go up to 24 atmosphere.
Yeah, that's
so we are now. You want to do one more IVUS? Or we are okay?
No, afterward.
Well, I still would think that it's going to be, but just looking at this inflation, I would say still it's going to be more than 2.0.
Sure.
So I'm surprised it's only 2.0. So, but that's why you need the IVUS, and it's super thick.
But also, George, I think what's important is it's not just what the MLD is. It's also like, did you get a fracture or not? Because if you have a fracture and it's small, it's still going to expand.
Right.
Stent. That's why stents work.
Exactly.
Yeah, just to clarify, the IVUS was after the high pressure balloon.
Yeah. And Kiski said that there was only one cut. Right, Kiski? How many cuts you saw?
Not like a clear cut.
So if you didn't see a clear-cut fracture, that's the strongest reason to, I think, use the IVL.
Yeah, it looks like the 2.0 just made a tunnel of exactly 2.0. 2.08. It was pretty circular exactly where the IVUS team showed us this cross-section. So it wasn't really MLD. It was probably max and minimal MLD, the same thing. That one spot was 2.08.
So, I mean, can you see a little better if you take some of the caudal off, maybe?
Yeah, we'll do, but then ostial circ we didn't see at all. But I'm going to move that. We had tried everything, believe me.
I know.
Okay, we are in the LED again. Yeah.
Maybe if you have a way to get rid of the top right shield a little bit better, so because we see a lot of lung, and that creates a lot of contrast. Please, cover that more. Cover that more, please.
Yeah. So now tell us now, what do you see?
Sure. So this is a distal left main. Yeah. At least area is much better. And
But did you do any cuts of the calcium?
I think so. This is like a kind of some fractures
Yeah, a little bit of cut.
by the IVUS. Yeah. And
Oh, this is
Yeah,
interruption.
you've
We saw
got
the cuts here
fractures.
now.
You've got fractures in 2 spots and maybe 3 spots actually. You got
Yeah, you're going to be
11
good.
o'clock,
That's going to be good.
6 o'clock, and 8 o'clock.
Yep. And a much bigger
recommend
lumen.
the
So I
IVL.
think
Suspect
we
you
could
can
modification.
expand
should
that
use
now.
the,
What's
you
that?
should use the IVL.
All right, let's see who is favorable in using IVL here. Dr. Duvurik, what do you say?
Okay, so I mean.
No, we use RVL now. This is after the IVL, my friend.
Yeah, they already did it. They already did it.
Oh, we missed that one.
Yeah. So you've got 3 fractures. I think it should be, okay.
If this is after IVL, there's nothing else to do, just, unless it's a lot. What was the size of the IVL? Is it 4.0? Sami?
4.0, yeah. And 4.0, we went up to 6 and then 8. Not 4 to 6,
Yeah.
6 and 8.
So that looks,
You
that
know,
looks
only thing is I
nice.
tell
Okay, then
everybody,
stand.
But,
don't
well-
go on the IVL balloon to 8.
Give us few details. How many rounds of IVL did you do?
We did a 5.
Well, how come not
rounds,
12?
Few of them only 5 seconds because of the hypotension. And knowing that we
Hypotension.
don't have a balloon
I
pump or
see.
impella on this case.
Yeah.
Andrew.
Yeah. Okay. Let's
But we're
go
able
back
to
to
do it 5.
let's go back to the angiogram, please. Yeah. Thank you. All right, Dr. LaSala, quick comment.
Yeah, I just think to remember is if you look at the histology when IVL is done, it's not just the radial fractures, you know, the 3 around the circle, it's longitudinal as well.
Yeah.
Right? And every modality that has more resolution shows that there's more fractures. So if you go from IVUS, if you go from OCT, if you go to micro CT scans, and if you go to histology, you see that almost each one of those modalities, it goes up another 20 to 50% in terms of the degree of fractures. You don't see the whole degree of fracture, in other words.
Yeah.
Any other comment? I see Dr. Sharma ready for a mini crush or a T-stent type.
So should we have
bifurcation.
Should we have IVL
mini
irrespective of the IVUS? The post-rota IVUS, should we have IVL irrespective? With the safety margin as good as it is, should we have just done IVL irrespective of the post-rota IVUS, which is what?
I agree. I mean, I'd
there's a
say that I
downside.
would have done the IVL and then do the, and then 4 IVL and then do the IVUS.
Maybe.
So
I mean,
I would
I-
have skipped that. I mean, it was pretty clear. If you want to achieve a really 4 plus diameter here, it's one thing to do rotablade or if the reference diameter is 3 or 275, and a different thing if it's 4 plus. I think you really need the bigger attempt for the.
Yeah, but the IVL, you know, but George, playing devil's advocate, the IVL is expensive, and if the IVUS had shown you that you already had fractures and you didn't have circumferential calcium, then you didn't need the IVL.
I doubt any patient like this one was included in any of the trials. So it's a little bit extreme, the situations we see here. So I would probably spend a little money to make it good.
No, but for years, cases like this were done without IVL, and they did very well.
Absolutely. You'd use a 2.0 burr and then a, 3.5 cutting balloon.
I think the balloon that expanded or didn't expand in one spot really told you a lot if you're going to come
That's
back.
different. That's
And I
different.
think that really was the marker. And then you can do whatever you want with imaging, but you still have to respect the old time balloon not opening up if you're going to do a bifurcation stent in the left main.
All right. So what sizes stent did you put and how you going to do pot
I'm
now?
just going to tell you 1 second. Yeah. So basically what we have done now is a 4.0, a 16, a Megatron in the LED, and 408 in the circumflex with a mini crush technique. And I know that let's take a picture, do the IVUS, and then recross. And of course, we had to do a kiss. Once you do a 2-stent approach, always do a kiss. If you do a stent across, if it looks good, no need to do a kiss.
Yeah, you need the Megatron
right.
just so you can see it through somebody with this kind of a BMI.
Yeah, let's see. Okay, let's a little better guide.
Well, let's see.
Radial 7 French. I'm sure we probably do now I think when Nitin used to be here, do a lot of 7 French. I personally do maybe 1 per year, 7 French.
Yeah, well, with the 7 French, maybe we can see a little bit more dye in this case, so that's another story. But by the way, everybody can see on the factoid, the bifurcate panel that always gives it step by step in an easy to understand
All
way.
right.
Very nice.
Okay, so we just do the IVUS of the LED, and then you go to the keen. Anu is ready on other side.
You're not
pretty
interested
nice.
in doing a pot with 5.0?
Yeah, so then we can just finish with the pot. Yes.
Yeah, I don't
Get a
think,
5 balloon.
you just do your regular, I don't know if you need an IVUS at this step, just do,
I would do a pot, though. I'd do a large pot. Looks great, though.
very nice.
Looks a terrific result, and clearly the bifurcation, or the crux of the bifurcation, looks very, very good.
Okay, I think this we are just doing it for the completion's sake now. You're right. You don't need any IVUS or so. Angiographically looks very good. We have done all whatever we need to do by all the books, or in terms of calcium modifying strategy, all have been done in this particular case. And now we just do a little bit of good. I think that's okay.
Show the IVUS screen on the screen.
You know, ironically, the place where you really need the IVUS is the
start forward.
osteocirc.
It's a
That's
native
where it always comes
eccentric
back, but that's the hardest place to get the IVUS.
Really nice result.
Nice reaction. Yeah.
That's good.
All right, just show it and we are done.
Is this IVUS towards the LED or towards the sun?
LED still will remain the LED, yeah. And remember, in this case, osteal circ was, yes, as Greg pointed out, of the Achilles heel of bifurcation, but it was very short lesion, as you saw. But here it looks quite good. And we just need to do a little 5-4 proximal pot, and lumen is terrific.
Looks very good. Terrific. Dr. Mehta.
Will be about 0%.
Dr. Mehta has a question, real quick.
Samin, quick question for you. The reason for you not to have put in the impella here was because the EF was good?
No, not the patient's body habitus.
Okay, and the second, I think the real teaching in this case, which you went so fast, was how exactly carefully the 2.0 burr was used. You know, it was back and forth so easily, but there was a little, it kept sticking in the inferior part of the left main. So very nice result. Samin, any precautions you take when doing IVL of the left main?
Yeah, so we talked about it many times. Patient become hypotensive. Just do a 5 pulses as we have done in our live webcast also. So 5, maybe just 5 pulses. Doesn't have to do 10. And of course, give a gap, we call a breathing room. And before you continue further. So now we have what balloon we have? Okay, so basically, if everybody's okay, we are done here.
Yeah, that was a terrific case. Thank you so much. Terrific case. Congratulations. And let's go across the hall.